Welcome to our deep dive into the fascinating world of nerve conduction and its disorders. Nerve conduction studies are often the first step in diagnosing peripheral nerve problems, providing crucial information that guides further investigation. However, interpreting these studies isn't always straightforward. There are common assumptions, like conduction block and temporal dispersion being unique to acquired demyelinating disorders, or hereditary neuropathies always showing uniform slowing, that can sometimes mislead even experienced clinicians. In this video, we'll unravel the complexities of conduction slowing, conduction block, and temporal dispersion, exploring how they manifest in demyelinating, dysmyelinating, and axonal neuropathies. Let's begin by laying out the basics of nerve conduction and why these features matter. At the heart of nerve conduction is the action potential, a rapid electrical signal generated at the axon's initial segment. In myelinated fibers, this signal jumps from one node of Ranvier to the next, a process called saltatory conduction. Here, voltage-gated sodium channels open, allowing positive ions to rush in and trigger the next segment. Speed and reliability of this process depend on several factors: the diameter of the nerve fiber, the thickness of the myelin sheath, and the length between nodes. When myelin is healthy, conduction is fast and efficient. But what happens when myelin is damaged or developmentally abnormal? That's when conduction slowing, block, or dispersion can occur, setting the stage for various neuropathies. Altatory conduction relies on intact myelin to insulate the axon and focus the electrical current at the nodes. When myelin is damaged, as in demyelinating diseases, the current leaks out and the safety factor for conduction drops. If the safety factor falls below a critical threshold, conduction fails, resulting in a conduction block. Sometimes the damage is so severe that the signal can't jump to the next node, leading to a complete loss of function in that nerve segment. Even before total block, slowing of conduction velocity can occur, and the timing of signals among fibers becomes desynchronized, causing temporal dispersion. These changes are key markers in nerve conduction studies and help differentiate between types of neuropathies. Conduction block occurs when an action potential fails to propagate past a damaged segment, even though the axon is still alive. This is typically seen as a drop in the amplitude or area of the compound muscle action potential, CMAP, when stimulating the nerve at different points. Temporal dispersion, on the other hand, refers to the spreading out of the CMAP waveform due to differences in conduction velocity among fibers. This leads to a broader, less synchronized response. Both features are hallmarks of demyelinating neuropathies but can also be seen in other conditions, making careful interpretation essential. To better understand these phenomena, researchers have used animal models. For example, injecting tellurium into a rat's tibial nerve induces acute segmental demyelination. Serial recordings show progressive decline in CMAP amplitude after proximal stimulation, eventually leading to complete conduction block. Pathological examination reveals myelin splitting and disruption near the nodes of Ranvier, with phagocytes cleaning up myelin debris. Over time, remyelination begins and conduction can be restored, though often with lingering slowing and prolonged latencies. These models help link electrophysiological findings to underlying pathology. Acute and chronic inflammatory demyelinating polyneuropathies, AIDP and CIDP, are classic examples of acquired demyelinating disorders. Electrophysiologically, they show a mix of prolonged distal motor latency, slowed conduction velocity, conduction block, and abnormal temporal dispersion. These features often vary between nerves and even between segments of the same nerve, reflecting a non-uniform pattern of demyelination and remyelination. Pathologically, segmental demyelination, onion bulb formations, and macrophage infiltration are common findings. Understanding these patterns is crucial for accurate diagnosis and management. In recent years, a new category called perinodopathies has emerged. Here, the problem isn't classic demyelination but rather disruption at the perinodal junctions, where myelin loops attach to the axon. Autoantibodies against proteins like neurofacin 155 or contictin can cause detachment of these loops, leading to conduction slowing, block, and temporal dispersion. Interestingly, pathology often shows axonal degeneration and perinodal dismantling, but not the segmental demyelination seen in CIDP. This highlights the importance of understanding the molecular targets in different neuropathies. Anti-MAG neuropathy is a chronic, slowly progressive disorder associated with IgM antibodies against myelin-associated glycoprotein. Electrophysiologically, it shows marked prolongation of distal motor latencies, often out of proportion to conduction slowing elsewhere. Pathology reveals characteristic widening of the myelin lamellae, especially at the perinodes. Unlike classic demyelinating neuropathies, conduction block is rare, but the unique pattern of distal slowing can help distinguish anti-MAG neuropathy from other conditions. Key distinction in neuropathies is whether conduction slowing is uniform or non-uniform. Inherited dysmyelinating neuropathies like CMT1 atypically show uniform slowing across nerves and segments, without conduction block or temporal dispersion. In contrast, acquired demyelinating neuropathies and some hereditary forms with perinodal involvement display non-uniform slowing, with patchy blocks and dispersion. This distinction helps guide genetic testing and management strategy. Charcot-Marie-Tooth disease type 1A, CMT1A, is the most common inherited demyelinating neuropathy, caused by duplication of the PMP22 gene. Patients show uniformly slowed conduction velocities, typically between 15 and 30 ms across all nerves and segments. Pathology reveals a moderate reduction in myelinated fibers, thin myelin, and frequent onion bulb formations. Unlike CIDP, conduction block and temporal dispersion are rare. The uniform slowing is thought to result from developmental defects in Schwann cell elongation, leading to shorter internodes and diluted current at the nodes. EMT1B, caused by mutations in the myelin protein 0 gene, and congenital hypomyelinating neuropathies present with very slow conduction velocities, sometimes below 10 ms. Pathology shows fibers with little or no myelin, and onion bulbs. These disorders highlight how developmental defects in myelin formation can lead to profound slowing, even without active demyelination. The clinical presentation often includes early onset weakness and sensory loss. ZMT4F, due to pyriaxin gene mutations, and myrisin deficiency both cause severe early onset neuropathies with uniformly slow conduction velocities. Pathology reveals very thin myelin, short internodes, and frequent onion bulbs. These findings underscore the importance of Schwann cell axon interactions in maintaining normal conduction. In myrisin deficiency, the pattern of internodal length resembles that of newborns, supporting a developmental origin. Hereditary neuropathy with liability to pressure palsies, HNPP, is caused by deletion of the PMP22 gene. Unlike CMT1A, HNPP shows focal slowing and conduction block at common compression sites such as the ulnar nerve at the elbow. Pathology reveals to macula sausage-like thickenings of myelin often at the perinodes. These focal changes make the nerve more susceptible to mechanical injury and block, especially under stress. Mutations in the myelin protein 0 (MPZ) gene lead to patchy non-uniform conduction slowing with conduction block and temporal dispersion. Pathology shows myelin thickenings, infoldings, and occasional temacula, especially at the perinodes. These features can mimic acquired demyelinating neuropathies and highlight the overlap between genetic and immune-mediated disorders. DMT1X, caused by mutations in the GJB1 gene encoding connexin 32, often presents with intermediate slowing of conduction velocity. In males, the slowing is more pronounced, while females may have normal or mildly slowed velocities due to exon activation. Pathology reveals loss of large fibers, clusters of regeneration, and remodeling of perinodal myelin. Non-uniform slowing, conduction block, and temporal dispersion can occur, sometimes leading to misdiagnosis as CIDP. EMT1C, due to LITAF gene mutations, and CMT4J, caused by FIG4 mutations, are rare inherited neuropathies that can show non-uniform conduction slowing, conduction block, and temporal dispersion. Pathology in these disorders often reveals segmental demyelination, thin myelin, and onion bulbs. These findings further blur the lines between inherited and acquired demyelinating neuropathies. Sometimes, patients with hereditary neuropathies experience sudden worsening, with features of conduction block and temporal dispersion. In some cases, this reflects a superimposed inflammatory process, such as CIDP, on top of a genetic disorder. These patients may respond to immunomodulatory therapy, but careful evaluation is needed to distinguish between genetic and acquired causes of demyelination. Mitochondrial neurogastrointestinal encephalomyopathy, MNGIE, is a rare disorder caused by mutations in the TYMP gene. Although primarily an axonal neuropathy, MNGIE can show non-uniform conduction slowing, conduction block, and temporal dispersion, sometimes leading to misdiagnosis as CIDP. Pathology reveals loss of myelinated axons and segmental demyelination in a subset of fibers. This highlights the diverse mechanisms that can produce similar electrophysiological patterns. Hereditary transthyretin amyloidosis (hATTR) is an adult-onset disease marked by amyloid deposits in nerves and other tissues. Early on, it presents as a link-dependent axonal neuropathy, but as the disease progresses, features of demyelination such as conduction slowing, block, and temporal dispersion can appear. Pathology shows amyloid deposits, thin myelin, and occasional onion bulbs. Misdiagnosis as CIDP is common, emphasizing the need for genetic testing in atypical cases. Acute motor axonal neuropathy, AMAN, is a variant of Guillain-Barré syndrome associated with anti-GM1 antibodies. Although classified as axonal, AMAN can show reversible conduction failure (RCF) and conduction slowing mimicking demyelination. This occurs due to antibody-mediated disruption at the node of Ranvier, leading to transient conduction block without segmental demyelination. Recovery can be rapid if axonal degeneration does not occur. Autoantibodies against neuropathin 186 can cause severe neuropathy with conduction block and slowing, sometimes fulfilling criteria for CIDP. Pathology shows loss of Schwann cell microville and occlusion of the nodal gap, but not classic demyelination. These findings illustrate how disruption of nodal proteins can mimic demyelinating features electrophysiologically, even in the absence of myelin loss. Neuropathies due to energy restriction, such as those caused by ischemia or thiamine deficiency beriberi, can present with reversible conduction failure. Early on, conduction block may be seen, but this often progresses to axonal degeneration if the energy deficit persists. The underlying mechanism involves dysfunction of the Na plus K plus pump, leading to sustained depolarization and inactivation of sodium channel. Vasculitic neuropathy is another example where conduction block can occur without classic demyelination. Early in the disease, amplitude reduction of CMAPs from proximal stimulation may be seen, but this usually progresses to axonal loss. Pathology shows necrotizing vasculitis, asymmetric fiber loss, and Wallerian degeneration. The conduction block is often transient and reflects metabolic failure rather than structural myelin loss. Critical illness polyneuropathy, often seen in ICU patients with sepsis or multi-organ failure, can also present with reversible conduction failure. Soluble factors like nitric oxide inhibit mitochondrial function, leading to Na plus K plus pump dysfunction and conduction block. If the underlying metabolic disturbance is corrected, recovery is possible, otherwise axonal degeneration ensues. Concept of reversible conduction failure (RCF) is important because it represents a potential window for intervention. In both antibody-mediated and energy restriction neuropathies, early recognition and treatment can prevent progression to irreversible axonal loss. Serial nerve conduction studies are essential for detecting RCF and guiding management decisions. One of the main challenges in clinical practice is distinguishing between acquired and inherited neuropathies, especially when electrophysiological features overlap. Non-uniform slowing, conduction block, and temporal dispersion are not exclusive to acquired demyelinating neuropathies. Some inherited disorders, mitochondrial diseases, and even metabolic neuropathies can mimic these patterns. A comprehensive approach, including genetic testing and careful clinical correlation, is essential. Bridging the gap between pathology and electrophysiology is key to understanding neuropathies. Electrophysiological findings provide clues about the underlying pathology, whether it's segmental demyelination, perinodal disruption, or axonal degeneration. Conversely, pathological examination can explain unusual conduction patterns and guide further testing. Collaboration between clinicians, neurophysiologists, and pathologists leads to more accurate diagnoses and better patient outcome. Sum up, conduction slowing, block, and temporal dispersion are complex phenomena with multiple causes. Uniform slowing usually points to inherited dysmyelinating neuropathies, while non-uniform patterns suggest acquired demyelination or certain genetic and metabolic disorders. Reversible conduction failure is a critical concept, offering a window for intervention before permanent damage occurs. Always consider the full clinical picture and use all available tools for diagnosis. Navigating the complexity of peripheral neuropathies requires a nuanced understanding of both electrophysiology and pathology. Be aware of diagnostic pitfalls, such as mislabeling inherited neuropathies as CIDP or missing treatable conditions like HATTR. Serial studies, genetic testing, and interdisciplinary collaboration are your best allies in achieving an accurate diagnosis and optimal management. Ongoing research continues to shed light on the molecular mechanisms underlying neuropathies. New diagnostic markers, targeted therapies, and improved understanding of disease mechanisms promise better outcomes for patients. As we learn more about the interplay between conduction properties and pathology, personalized medicine becomes increasingly possible. Stay curious, stay updated, and always approach each case with a critical and open mind.